Good afternoon. Thank you for tuning in today to our webinar all about addressing communication challenges in disconnected Indigenous populations. This is the monthly meeting of the Connected Healthcare Community, which started off as a group of Bright Squid Secure Mail users and now has expanded anybody who's involved in providing patient care in a team-based setting or looking for ways to do that, such as integrated care networks or the like. While we meet today on a virtual platform, it is important we acknowledge and pay tribute to the traditional lands, meeting grounds, gathering places, and traveling routes of the Indigenous peoples who lived, live, and cared or care for the lands from which we all join this meeting. For me, those are the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, and the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bears Paw, and Goodstoney First Nations, and the Métis Nations of Alberta, District 5 and 6. We make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting. Today, I'm really excited to welcome our presenter, Michelle Hoeber. So Michelle is a TSAG eHealth manager and the clinic manager of the Alberta Indigenous Virtual Care Clinic, which has Michelle take us through some of the information about it, which has really taken off since it was launched. Michelle, in 2020.
Yes,
is that right?
October.
Yeah, so it was a COVID measure that has stayed around and flourished in terms of use and importance. So, really interesting topic today to go through that stuff. The quick introduction about Michelle. She's really been working in eHealth and telehealth implementation and management for Michelle, like since before it was really a thing.
Yeah, grandmother into the knowledge. So since the early 2000s. So.
Yeah, so really excited to have Michelle's insight, and she's going to take us through sort of the setup and implementation of AIVCC. Really, the challenges that you've been faced with and addressing is that some patients really are hard to keep track of and hard to connect across Indigenous communities that you serve. And so looking for ways to both support that connection on an ongoing basis while also not introducing a ton of extra administrative burden for your MOAs who can't spend all their time chasing people. So that's one of the big issues that I know you look to address, and I know we helped with some of that, but there's lots of things that you've done.
So I'm just going to take you guys through like a little introduction of what the Alberta Indigenous Virtual Care Clinic is and introduce some of the challenges that we faced and some of the solutions that we found that worked well with us. So I'll give you a little bit of stats throughout as well, so we can just move through these first slides. So what is the AIVCC, a little bit about our shared mental health program, our evaluation that we've done, who is using the AIVCC, challenges and solutions, and what we've learned, and our next steps. So what is the Alberta Indigenous Virtual Care Clinic? So we're a virtual clinic available to anyone in Alberta. Our target audience is any Indigenous person or their immediate family members. We're open, like I said, 7 days a week. You can read the times there. We have a toll-free number, and those are answered by medical office assistants during open office hours. We also accept web requests from our website, which allows for some basic information to be submitted. We don't allow a large amount of information to be sent to us through that means, and then a MOA would contact you at the number provided. Or you can send an email through the secure mail to our clinic and request an appointment, and then an MOA would, of course, follow up with that request. We opened October 28th of 2020, and as you can see below, we've built the clinic quite a bit over that period of time. I think we started with 15 physicians, like Jeff had in the introduction, and 2 medical office assistants. Now we're up to 7 medical office assistants, and we have some other clinicians that have joined us, like the 2 psychiatrists, 7 psychologists, 2 patient navigators, and a clinic coordinator. The AIVCC started as a primary care clinic with access to our primary care physicians that are under a contract through an ARP agreement. So it's a very long name, but it's the Indigenous Wellness practice clinical alternative relationship plan. And that just allows the physicians to be more salary-based, so it's not fee for service. So they can spend a little bit more time with patients and listen. They also work in-person clinics outside of our clinic at other facilities serving Indigenous or other vulnerable populations. We have a team-based care mental health team consisting of psychiatrists, psychologists, the patient navigators, and the physicians. It's really important to have that team approach because a lot of our patients, we want to rule out any medical conditions that could be causing some mental health issues or concerns for the patient. We also want to make sure that we're addressing all the patient's concerns because some do lead to other things. So if maybe if you're not looking after your diabetes care or your condition, your mental health may be suffering as well. So if we can do it collaboratively at a holistic approach, the patient benefits. And then we have patient navigators that support the patient accessing services outside of the clinic. And those navigators also work with the patients to reach those personal goals. So what maybe the physician sees as their primary goal might not be what the patient feels is their primary goal for assistance. So say someone is homeless, but it's more important for them to connect with their children in the care system. The navigator would assist the patient to meet that goal. And then maybe the next step after reaching that goal could be on finding appropriate housing. We also have a registered nurse that is very part-time with us. She does review charts and looks onto NetCare for any patients that we've seen 3 times or more. For those immunizations, if they have a chronic disease, if they have followed through with their regular testing, cancer screenings as well. And then she prepares those lists for the physicians to talk with the patient at their next visit. So then those outstanding tests and screenings can be requested through requisitions. The registered nurse and the medical leads are also collaborating with external clinics and building those important relationships. I'll explain that a little bit later when we get to some of the issues that we come up with. And the entire team works virtually, which is really important to note. Our shared mental health program addresses individual counseling ages 13 and over for any Indigenous AIVCC patient. Now, we also have monthly case conferences, which involves plus we have informal discussions and conversations between members, and that's that team approach. But we also have those monthly case conferences where a physician or one of the counselors can bring a patient forward to discuss what is happening with that patient. There are really great learnings that are happening, and that team building approach is really important that take place in those case conferences. So even if you don't have a patient that's being presented, you are welcome to attend if you are a clinician because of those educational opportunities. We do also host a few CME events for the family doctors at our quarterly meetings. So we've done complex PTSD, we've done cannabis and patients' health. We also do ADHD assessments, and we started psychoeducational assessments in the late October of 2023. We started also couples counseling, but both individuals need to be Indigenous because we have limited funds, and so we are focusing that service just on Indigenous clients. We run a 12-week DBT group. We've had an 8-week addictions recovery group in partnership with Bentero Healing Society, and then we also had an 8-week intuitive eating group. Now, it was really important for us in the very beginning to have an evaluation of the Alberta Indigenous Virtual Care Clinic. And so we partnered with 2 very strong research people, and Dr. Pam Roach and her team at the U of C provided recommendations and feedback. They developed a tool that assesses virtual encounters. They had 19 interviews, 7 with the physicians and 12 with AIVCC patients. And there's a very extensive report on those findings. And then we also created a patient and a provider survey, and those were distributed to the providers and the patients. And we got a very good response back from patients. And overall, the clinic has done very well. It was very positive. And we do have final reports available for those. And then the other partner that we partnered with is Dr. Richard Oster and his team at the U of A and the Indigenous Wellness Corps. And they were able to provide us with a report on how AIVCC is doing based on that patient and provider survey and the statistics that we were able to gather from the usage of the clinic. And one other mention I think is important to have is AIVCC was a part of the MAPS initiative, and we were recommended in the final report. You can go to page 37, and I just pulled up, it provides high quality care, reduces the burden of acute care and continuing care, addictions and mental health and other primary care services within the province. So being virtual in nature, it is also highly cost effective. So there are some criteria that were outlined to meet in regards to Indigenous health, and the clinic does align very closely with many of the MAPS report recommendations. So you wonder who's using the AIVCC. So I kind of broke it down. This is from October 28th to March 31st of 2024. So it's about 3.5 years worth of data. We've had about total of 25,470 appointments requested. We've had 21,403 successful appointments, which gets us to about a 9% no-show rate, which is really quite low in comparison to in-person clinics. And there's probably a few factors that run into that. So we can go through those when we get to the challenges and solutions. Just to show some growth by quarter, the different colors are the different years. As you can see in the pink, we did have some significant growth over the months, the first few months of that year. And then if you look at the green line, that's this current year of 2024, and we've seen another significant jump this year in comparison to the other years. Other people really prefer to see linear graphs. So here's a nice linear graph of our growth, and we're pretty steady with that linear line of growth. So sometimes we're a little above it, sometimes we're right on the lines. Our physicians use many different diagnoses, and it's too hard to graph the amount of diagnoses used. So we took all the ICD-9 codes and we put them into these 27 different categories. And then we ran this report. So you can see we have a wide range of reasons and diagnoses for the patients to reach out to AIVCC. The number of appointments by gender and age range, you can see that we're very popular with the female demographic in the ages of 19 to about 68. But it's really interesting to see that we do still have some that are over 89. We have 12 females that are over 89 and 2 males that are over 89 used in our clinic. So just a neat demographic to see it spread out this way. And just some examples of what usage we have. So the psychologists have initial assessments, and then they have follow-up. And then the patient navigators, they started in September. So they've had a lot of follow-up appointments, but you can see that their intake has been a little bit smaller, but they haven't been around for as long as the psychologists. And then who is using it for the mental health? I can't put the psychologists on the same graph as the other mental health activities because it skews the graph and you can't see the numbers. So these are just some of the other mental health services that are provided. So the psychiatry appointments and assessments, the adolescent psychologists. We also have EMDR individual sessions. So ADHD assessments for both adults and adolescents. So getting into the challenges and solutions, and that's probably why you are attending this conference. So there is a shortage of primary care physicians throughout Alberta. That was something that we knew, but we didn't know if our clinic could fill a little bit of that gap. We're not the full solution, but we are part of the solution. And so we provide the ability for patients to call a toll-free number or send a secure email or request on the website from anywhere in Alberta and get an appointment with a primary care physician that's experienced working with Indigenous people and provide culturally safe care. So the patient can have a video or a phone appointment with any of the clinicians. So that was really important to us. A great example is if a patient is entering into a treatment center, we can see them through detox, through to the treatment center, and through their return to home, and follow the patient. And it doesn't matter where in Alberta they are, we can still follow that patient. So we have that continuous care model in that regard. There have been some very negative encounters with local services and clinicians. We heard that loud and clear through our interviews with patients. So we wanted to reduce the barriers for patients to access care. We allow extra time for appointments. We can have more than one concern, which is really important to patients. They may identify as one concern for the MOA, but when they start talking with a physician, there's usually more than one concern that they're bringing to the physician's attention. And we try our best to make sure that those concerns are most appropriate for virtual care, but sometimes there are some that are not appropriate, and we need to take action to better serve that patient, and we may recommend that they be seen in person. I think the other thing with the very negative encounters, loud and clear, the patients have said that when they go to some of the local services, they're not being heard. And so we want to listen to the patient. So the next thing was, how do we provide private information to patients that we only commute virtually with? So Bright Squid was a great solution for us. The secure mail we use to communicate with patients. We have a shared inbox, so all of the staff have access to the same inbox, so it's not going to just one provider, and we're able to not miss those messages as they come in. We get notification in our email that we have a message waiting for us in Bright Squid secure mail. And then it allows us to go and look at if the patient has opened the email message that we've sent to them. So sometimes when we're trying to reach out to clients, we've tried them on the phone, we've tried sending an email, and if they've not opened the email, that is an indication to us that they haven't got that message. So maybe we've got to send a letter through snail mail, actually letter and stamp and with the post office. So there's those ways that we've determined to reach. We also can send information to providers or insurance agencies through Bright Squid as well. And that was really important because we're getting a lot of forms completed that need to be sent on to either referral agencies or other providers or those insurance companies or the government for disability tax credits. And not all patients live in a connected home or have access to the internet. So they can't just have an app-based solution because a lot of our patients have pay-as-you-go phones, so they have to buy minutes. And so sometimes we have that flexibility of being able to, this is their regular number, but today they're using their auntie's number because they don't have minutes on their phone. So we have a system built in that we can put a temporary phone number in, and the clinician knows which number to use. And then also, we do allow patients to attend if they live on a reserve to go to their health center, and we can connect with the video conferencing equipment there. Or if they are an urban homeless person, they can work with the support workers, and we can connect with the support workers and use their facilities to connect with the patient. Or pharmacies as well, they call us as well. And how do we reach? I kind of covered this one already. The MOAs try the patients 3 times, either by phone or by email. A lot of our patients move around. So if they were in the north part of the province, one month they might be in the south part of the province the next month. So having that ability to reach out wherever they're at in Alberta is it's a better solution for us, and we can keep that continuous care. How do we remind patients about appointments? We use a patient reminder that we've set up through Bright Squid. They have the ability to have access to some of our EMR, and it's very limited what they have access to, but they would send out a patient reminder message either through email or through an SMS text message. And then the patient has the ability to cancel, to confirm those appointments, and then they're getting it in the way that they have set it up to have that reminder. And then We've used Bright Squid to create some customized forms as well. So the patient, if we need them to fill out a complete form, we've created some, not all our forms are this way, but I think we have 6 or 8 forms that are set up this way that we use on a regular basis. We could send it to them and it will show up on their phone and they can just complete it and submit it, as opposed to having to download it, complete the form, and then reattach it somehow and find it on their computer. So, and that seems to work really well also for pictures. So we will send an email with instructions on how to send us back pictures. It's just a quick form. They click the pictures on their phone and submit. So it works really well. And then we also use Bright Squid to send out the privacy surveys. So we've learned a lot over the last 3.5 years. What started as a COVID clinic has grown into a support that's required for the Indigenous people of Alberta. We have not reached all of the Indigenous people of Alberta. We don't, I'm not sure if we'd have capacity to support all Indigenous people, but not everyone lives in a connected home. There are barriers to healthcare, such as availability of family physicians, transportation, culturally safe space, costs, etc. It's really important to have that expanded clinical hours of operation. So people that have full-time jobs and are not able to step away from their job during the day have the ability to call in the evening or on the weekend to have a medical appointment with a physician or one of the psychologists. 30-minute appointment slots are important because sometimes you need that extra time for that connection time, and you need those extra minutes to discuss more than one concern. And the external partnerships are really important because we need someone to do that physical piece for us because we are all virtual. So it's really important to have those partnerships in the community. Increasing the complex mental health presentations have highlighted the importance of having that collaborative mental health care team. And then not all patient concerns are appropriate for virtual care. So we've had to create a process for referring these patients onward to in-person providers or to 811 to have those screenings or the Indigenous support line. And we do have a way for those patients, if they were appropriate, that they will be referred back to us. So, and then patients have to be seen within 72 hours if we get a referral from 811 or the Indigenous support line. And these are just next steps. So we're hoping to explore some clinic expansion. We have a few physicians that are looking to do a hub and spoke type model. They're going to be using a TELUS mobile health clinic van supporting 2 Métis settlements. So we will be able to support those physicians when they are providing a short period of time to connect to those communities outside of their in-person visits. Cancer screening we want to look at, and other risk screenings as well. Further collaboration with local healthcare providers, evaluation of the clinic and their benefits for both cost savings to the wider Alberta healthcare system. I think it's important to show some of those benefits. And collaboration with communities and external agencies. We're all in this together. We can support one another. And we would like to do another patient survey in the near future. That's all I have for you today. Do you guys have any questions?
That's really good. Thank you, Michelle. And so thorough and really interesting to see the progression and all the learnings that are associated with it. It's really cool that you've been able to measure things as you go along and taking those steps. We do have a couple quick questions for Michelle. So how does a patient get accepted for this service, Michelle?
It's just calling in and we'll register you. It's not an acceptance or not. The physicians will see non-Indigenous patients that call in. We just restrict the mental health therapists to have just Indigenous clients.
Another question is what we talked a little bit about, but what specific or a couple admin processes really helped accommodate the growth in demand and utilization, because you had quite a steady curve with some kind of steep bumps there as well. So how did you adapt to manage that without just expanding one for one?
We have limited dollars for MOA's support, but as you can see, we've been able to ramp it up a little bit due to the number of calls coming on. We get funding from Indigenous Services Canada, and they were able to boost our funding a little bit. And so we were able to get that additional person on to support the number of calls coming through. I think it also runs when we advertise a little bit more through the different means of Facebook or sending out posters to communities and Métis settlements and or different support agencies. It's a little tricky, but you just have to have that flexibility.
Great. Yeah. One final question we'll get to just before we wrap up, because we're at our time here. What barriers to patient adoption for, I guess, the services, but also the connectivity tools like the Price Good Secure Mail, for example, or the virtual access within the communities? What barriers have you experienced with patients adopting those?
Well, I think having the flexibility of having phone calls or video has worked really well for our patients, because some communities have great cell phone service, and so they have that flexibility of being able to be at home, but some have to rely more on Wi-Fi because their Wi-Fi connection is stronger than their cell phone service at home, and they may have that Wi-Fi connection at home or wireless connection, internet access. So we have that flexibility of going on to video instead. Some of our patients have to drive for 10 minutes to get that cell phone service, so having the ability to take those phone calls in the car with the patient just works. I think that's the key, is having that flexibility and not just providing one singular solution.
Great. I think that's really important, right? If we're too focused on one avenue in or one way to connect and access for patients, it gets pretty difficult and limiting. So, Michelle, thank you so much for taking the time to spend with us today and presenting all about the clinic, and really appreciate you doing that and putting this presentation together. So thank you very much, and thanks everybody for tuning in.
If you have any questions, reach out. Happy to connect.
Perfect.
Thank you very much for attending today.
Bye.
Bye-bye.